Hello, guys. So, in this topic of cornea continuation, we'll be talking about keratoplasty and different other things. Okay. So, the first and foremost thing, there are two types of keratoplasty major that we need to understand. One is a penetrating keratoplasty. Please do write with me. One is penetrating keratoplasty, other one is lamellar keratoplasty. So normally if you look into the layers of the cornea, the cornea consists of the outer epithelial layer. Then this is basically the Bowman's membrane, and then you have the stroma. The stroma consists of type 1 collagen fibers and glycosaminoglycans, which gives a perfect contour, because of which there is a corneal transparency, as I already discussed in cornea 1. Okay, transparency. And this is basically the Descemet's membrane. This is basically the Descemet's membrane. And then what you have here is the endothelium, and I already talked that these endothelium is very important for maintaining the hydration. So dehydration, maintaining the dehydration of the cornea. Remember, the cornea must be always dehydrated. If there is any hydration in the cornea, that is basically nothing but that is actually cataract. That is basically corneal edema. And cataract is actually hydration of the lens. Okay, so hydration of lens is basically cataract. And if there is hydration of the cornea, that is corneal edema. Now I talked about penetrating keratoplasty and lamellar keratoplasty. So what are the different indications for these type of keratoplasty? So very important is certain diseases like keratoconus. What is keratoconus? Keratoconus means because of excessive, this cornea being thin, and because of that there is ectasia of the cornea. So if you look into this diagram, so this is actually keratoconus. Okay, so what you can see here is actually keratoconus. So this is a conical protrusion of the cornea, and this conical protrusion of the cornea, what you see here, it's basically because of the defect in the collagen. Collagen of what? Collagen is basically present in the stroma, right? So any defect in the stroma, that will lead to keratoconus. And keratoconus becomes one of the indications of corneal transplant. Okay, and keratoplasty. Now, next thing what you need to remember is corneal degenerations, corneal dystrophies, and corneal opacities. Now, corneal opacities, corneal dystrophies, and degeneration, I will talk more on this session itself. For now, just remember the names. Okay, if there is bullous keratopathy. Now, what do you mean by bullous keratopathy? Bullous keratopathy means, suppose this is your endothelial cells. Okay, and there is this ballooning of the endothelial cells, and there is, inside this ballooning there are some fluid. Okay, and if this, this bullous, if it burst, then there is excess pain. Okay, so if in any ways, if there is bullous keratopathy, this happens usually when the corneal endothelium is less than 500. Normally it should be 2500 to 3000. Okay, and this differs in the case of children and adults. The number differs. Okay, and it's very important for us to know that at least around 2500 number of endothelium is required for a perfect transplant. If there is no enough amount of endothelium for perfect transplant, then we can't transplant the cornea. Why can't we transplant the cornea? Because while transplantation, also around 500 endothelial cells, they get damaged. Okay, and if there is damaged endothelium, that will eventually lead to a very bad outcome. So if we say exact number, this 2500 to 3000 is actually present in adults, and in children it's much more. It's 3500 to 4000. Okay, and the unit for this is cells per millimeter square. So 3500 to 4000 cells per millimeter square. Okay. Now, very important thing that I will be discussing in this session is keratoplasty and different corneal dystrophies, degenerations, and all these things I will discuss. Okay. Now let's focus on penetrating keratoplasty. So when we talk about penetrating keratoplasty, in penetrating keratoplasty, what should we remember is it's a full thickness corneal transplant, isn't it? Full thickness corneal transplant. And what we need to remember is in full thickness corneal transplant, we take all the layers of the cornea, ranging from the epithelium to the till the endothelium. Now, if we talk about lamellar keratoplasty can be of two types. One is anterior, other one is posterior. Anterior is further divided into superficial and deep. Posterior is divided into Descemet's membrane stripping automated keratoplasty, and other one is actually known as Descemet membrane endothelial keratoplasty. Okay. Descemet's stripping automated keratoplasty. There is no membrane, okay, over here. So Descemet's stripping automated keratoplasty. Descemet's stripping. Now in this Descemet's stripping, remember there is an S. So we take in stroma also, along with the Descemet's membrane and the endothelium. But in Descemet's membrane endothelial keratoplasty, we just take the Descemet's membrane and the endothelium. We are not taking the stroma. In the lamellar keratoplasty, anterior, superior and deep, in superior we take less than 1/3 of the stroma. In deep we take more than 1/3 of the stroma, along with the epithelium and the Descemet's membrane. So you have this epithelium, then you have this epithelium, and then what you see here is actually the Descemet's membrane, then you have the stroma. So if we take less than 1/3 of the stroma over here, this is actually known as superficial. More than 1/3 of the stroma, then that is known as deep. I hope we are clear till here. Okay. Now next thing that we have to remember is what are the different complications? Different complications of keratoplasty is, remember, so we are taking this cornea, and then we are transplanting this around 0.5 millimeter cornea to someone's other's eye. So the corneal thickness may slightly differ in one or the other individuals. Okay. Because of that, there might result in something which is known as an astigmatism. Okay. We are doing a surgery in the eye. Okay. Any surgeries in the eye may lead to an inflammation. Right? May lead to an inflammation. If there is an inflammation, why might there be an inflammation? Because of certain infections. Infections is the most common. An infection, it is called by staph epidermidis. Staphylococcus epidermidis. Remember, infection and inflammation, it leads to exudations, and that exudate, if it goes and stays in the trabecular meshwork, like this, that leads to glaucoma. Clear? Similarly, what might happen is, like, we just transplant the cornea and then we give radial sutures to fix this. These sutures may be weak. So there might be protruding sutures. Okay, there might be protruding sutures. There might be loose sutures. I hope we are clear till here. Okay. Now remember, normally cornea does not have HLA. Even though it has HLA, graft rejections is, it's very rare. So it is said that cornea is immune privileged. Cornea graft rejection is uncommon, okay, because it is avascular, it has minimal HLA expressions, and it has an absent lymphatic structure. Okay, remember there is one saying that if there is a female patient then I can use this female patient's cornea in both males and females. But in the male patient's cornea can only be used by males. So this is just gender bias thing. Okay, this you might remember, you might not remember, but this is interesting. So I just told in this session. Okay, so let's talk about other topic. So we want to talk about graft rejection. So if anyways there are graft rejections, we need to know that if there is an epithelial graft rejections, if there is a descendants membrane graft rejections, stromal graft rejections, or endothelial graft rejections, what are the different names? Okay, so this ophthalmology is all about names. It's very difficult to understand. Case dots. Okay, if there is graft rejection in the epithelium, graft rejection in the descendants membrane is known as descendants membrane, or this is also known as subepithelial. Okay, or descendants. Kramer's dots. Stroma, stromal haze. And endothelium, see, endothelium has the D, okay, endothelium, D, and D for khoda dost. DD, a lot of D's, right? Khoda dost lines. So these are the different names that we need to remember. KAYES, case dot, okay. This Kramer's, the spelling is incorrect. KRACHMER, KRACHMER, Kramer spots, not even dots. I also get confused. Okay, that is why we need to revise a lot of times. Very important for revision, ophthalmology. Kramer's spots. Write with me, okay? Write with me. Kramer spots, endothelium D's, so khoda dost line, epithelium case dots. I hope we are clear. Now remember, there is one more complications. In the complication, I just forgot to mention one important. It has a triad. Okay, so let me just make a diagram and explain you. So if this is your iris, okay, just make that this iris like this. Okay, this is my style. This means iris has been atrophied, and when you talk about the pupil is very, very big. So this is known as fixed dilated pupil. And I already told you, because of the inflammation, there might be a glaucoma. And inflammatory mediators causing glaucoma, it is actually secondary glaucoma. And anyways, if there is secondary glaucoma, iris atrophy, and fixed dilated pupil, this is a triad, and this is known as Uretz-Zavalia syndrome. And this is a rare condition, okay? Uretz-Zavalia syndrome, very, very rare. Now, let's talk about the major topic of this session, corneal degenerations. So first of all, I will list out the corneal degenerations. Corneal degenerations. I know this pen is not writing well. Corneal degenerations. Okay, I'll start this corneal degeneration in the next slide.